I'm Senator Randy Robertson. This is a subcommittee of the Insurance and Labor Committee of the Senate. Myself and the other senators on this committee have been tasked by Chairman Larry Walker to look at this legislation carried by Senator Huffstadler. And this is going to be rapid fire. We're going to try to get as much information as possible so that when we walk out of here, we're educated enough to explain this legislation to Chairman Walker and let him make a determination as to the will of the chair to move this legislation to wherever he feels it's best to go. It is Senator Huffstadler, so I would encourage everybody to pay close attention because he talks fast and a lot of times he talks over our head. So we'll try to set a pace where we can all understand what's going on. On with this subcommittee is Senator Mike Hodges of the 3rd. And the Dean of the Senate, Senator Ed Harbison of the 15th. Anybody that's going to speak today, there's a really good chance we're going to interrupt you while you're talking if you say something that we don't understand. And we're going to ask a lot of questions. And so please don't be offended. If I do offend anybody, it's not on purpose. It's just a talent I have. And I don't care. So, Chairman Huffstadler, I'm looking at LC 461012, Senate Bill 60. Is that what you have? Okay, sir, the floor is yours if you would explain this legislation in detail to the 3 senators in front of you.
All right, thank you for hearing this bill today. Senate Bill 60 deals with PBMs, pharmacy benefit managers. You're going to see a lot of definitions in here, and so I'll try to go through them. But basically, a health insurer has a duty of care. A health provider has a duty of care. This is simply trying to say that a pharmacy benefit manager has the same duty of care as we do to provide care in the best possible manner to our customers in the interest of all.
Senator Huffstadler, is duty of care defined in this legislation?
You've got a duty of care definition in there. Let me go back to that page. So if you look on line 192, it talks about duty of care, good faith dealing. Previous to that, let me go back to that section here.
Because reading through this, the reason I asked that, is there a clear definition of duty of care, or is that something that we're going to hand off to the Commissioner of Insurance to develop? And
well, he would develop regulations around it, but well, and I'll let the lawyer speak to that lawyer question, I guess, if that's possible. But
I apologize for asking a lawyer question. That's never been my intent.
Yeah, not a numbers question, a lawyer question. Sure,
that's right.
In the definitions, there's a lot of definitions, but in our code 2646, speaking as a lawyer, covers who is a PBM. In my opinion, they're pretty vertically integrated and incestually integrated, so you have to kind of define this to get all the group in there. They've been really good at skirting past legislation. And so if you look at lines 22 on to about 46, it's putting in the definition, and this is nationwide language that would put in the definition of who they are, so that they don't shift off subsidiaries.
Now, you say it's nationwide language. Who developed the nationwide language?
This is language that was brought to me by some individuals here that are lobbyists, just like they're representing their people, just like Skin and Cash represent very skillfully the pharmacy benefit managers over the years.
Does it disturb you at all that we have two lobbyists in the room named Skin and Cash?
Yeah. Well, I would say they're probably going to speak against this, and some much better looking lobbyists might speak on the other side of this
I
issue.
hope there's somebody better looking than Skin and Cash.
Yeah.
My question on that definition is, and I would guess, and this is me asking you, isn't it true, I guess, that each of those individuals, because they have different responsibilities, the type of care they would be mandated to have would be different also, right?
Well, they have, you're talking about PBMs as a whole?
Well, I'm talking about PBMs, I'm talking about the healthcare system, I'm talking about the insurance company. They all have duties of care, but they would be different, right, based on what their responsibilities are within the system.
Well, I'm not sure that legally that the PBMs have a duty of care under the current law.
Currently, you would say,
Yeah.
right? Okay.
But basically, you've got several large PBMs, and these definitions try to incorporate them all into there. The rest of it, if you go to page 3, you're defining who is the insurer, health plans. We always have to have these definitions so that when you finally get to the bill, what you're doing. Page 4, the maximum allowable cost, national average drug. Have to define who a pharmacy is, and pharmacy benefit fees, pharmacy benefit managers, and how the negotiation is done. And then if you get to line 111, pharmacy benefit manager duty means a duty and obligation to perform pharmacy benefit management services with care, skill, prudence, diligence, fairness, transparency, and professionalism, and in the best interest of the insured, the health plan, and the provider, to perform such services as consistent with the requirements of this chapter. So,
And real quick, who's their duty and obligation to? How do you interpret who their duty and obligation is to?
well, it's the duty and obligation, as it says, in the best interest of the insured, the health plan, and the provider. So they've got a duty of care to all of them, I would say. The patient, the person providing it, and to the health plan itself.
Are PBMs, in putting this legislation together, do you believe that, or have you discovered, and can you educate us, who do PBMs work for? Who pays PBMs?
Well, they're paid by a healthcare provider to manage cost, and so there's obviously going to be an incentive to save money.
So is their obligation to the individual that they're contracted with, or is their obligation to the patient who receives the medication?
Their obligation is who they work for, and that would be the insurer.
Okay, thank you.
Just quickly go past that definition. It's 116, what a point of sale fee is, who the provider is, rebates, and if you go to page 6 there, retroactive near the bottom, what spread pricing is, what steering is. But then when you get to the final section, section 3 on page 8, what we're saying, line 180, pharmacy benefit manager, the PBM owe the pharmacy benefits manager duty to any insured health plan provider that receives those benefits. And if you go down to some of the highlights of that, because I know you don't want to read the whole thing here, but 189 appeals in a transparent manner to insurers that's consistent with the best interest of insured, and to disclose all conflicts of interest to insured. line 192, near the end of that, it says that they include duty of care and good faith and fair dealing. And then going to the very last page, page 9, they have to provide transparency to providers about the amounts charged or claimed, and that's been a bear to get that. That's the reason some of the definitions in the earlier part.
It's been a bear to get it. Could you explain that?
Well, I've seen legislation in the past that got kind of picked apart by lawyers, and they found a loophole to not do what the legislature intended to be done in the past.
I think that happens a lot in this building, doesn't
I
it?
think it does. So the biggest part of this is lines 204 to 207 that says when there's a conflict between the pharmacy benefit manager duties owed, the pharmacy benefit manager duty.
Real quick, you said 204?
204, yeah.
Okay.
Last page says where there's a conflict between the PBM duties, the pharmacy benefit manager duty owed to an insured shall be primary over the duty owed to any other party, and the pharmacy benefits manager duty owed to a provider shall be primary of the duty owed to a health plan. The health plan is in there. They make money. I mean, that's their job, and they have to make money. But we've seen too many cases where care is denied, and this is saying you've got to take care of the patient. My understanding of the law is that they don't have that duty of care right now that the health plan does, and this would put them up there just like the health care plan, the health care provider have that duty of care.
I'm sure you have an expert in here that can probably help us understand that, but how do you picture that duty of care from the PBM standpoint?
How do I picture it being done?
Correct.
That when they'll have a legal obligation to provide care, too often medicine is denied and delayed, and people suffer. And there's not a lot of recourse right now in that situation, other than you try to appeal. The doctor may spend hours on the phone trying to appeal decisions, but there's not really any recourse when that happens.
What role does the PBM play in denying care or providing care if their primary obligation is to acquire the medication requested by their employer, by whatever healthcare program or pharmacy or whoever they work for?
Well, several ways they do it is they don't, they're trying to save money, and they don't provide quite often what could be life-saving medicine, or don't provide it in a timely manner. It takes real long to get it for people who may have a cancer condition or something that need it very quickly. And there's also, I get off in other areas, but steering and stuff like that. But I think I want to focus mainly on this, that there needs to be a duty to provide health care that's needed, that would be recognized as needed, and not deny it and keep people from having what the healthcare providers think they need to save their life in many cases.
Thank you. Senator Hodges, what mic are you on? Senator Hodges, what mic are you on? 10. You're on?
10, thank you. Senator, thank you for bringing the bill. The concept of PBM is not how long have they been around? That's not that old, is it?
It's, I don't know, maybe 20 years or so.
20,
I'm not sure.
Not as long as the providers and the insureds and
right.
all that. So over the years, providers and insureds have had a duty of care thrust upon them, or they've accepted it, a duty of care to the person actually receiving the care. If I'm the provider, if I'm the insured, what really matters is that I, as the insured, get what I need. Mm-hmm. Correct?
Correct.
Whether I'm that's the duty the provider has to me, that's the duty the insured has to me. And they've been around a long time. The PBM thing, in the last 20 years or so, and this is a question, basically was PBM concept was dreamed up to try to help control the cost of drugs, right?
Bring efficiency and
Bring
control.
efficiency into the drug purchasing process for both providers and insurers, right? Okay. So in all this time, they've not had thrust upon them that same duty of care. So what they might, I'm asking you if this is your case.
Mm-hmm.
So what they might do is that they might, I mean, their motive is a basic profit motive. It's to keep the costs down as much as they can, cost of drugs.
Correct.
So they might not have the same intention toward me, person receiving health care. They're more worried about keeping the cost of the drug down to the provider. They're more worried about keeping the cost of the drug to the health plan down than they are making sure that I get the drug that I need. If there's a generic, in other words, like if there's a generic drug that might be used, but my doctor doesn't want to use it, then the PBM's going to lean on going to lean on somebody to make sure I get that. If they're going to pay for it, that I get that generic.
And I think if they were independent, and I think the original concept may have been good if they were independent.
Right.
That might be good, but they're owned by.
That was my next question. Originally, were PBMs basically independent? I mean, originally.
Well, originally they were trying to be set up that way, but there's really three large ones, and of course they're owned by people.
And how has that developed? How's the PBM gone from being basically a third party that oversees cost to being to having skin in the game?
Yeah, well, it's just groups have taken over PBMs, and control them through their.
Say insurance companies that bought PBMs?
They've.
Or pharmacies?
Well, I think this is, in some cases, yeah, like CVS has one of the big ones, and so if you work for CVS, then your incentive would be to steer the business to CVS. You might pay somebody, an independent pharmacist, less than you would pay them if you can get away with that, and they have been able to get away with that in many cases. They get back rebates and items, so they're in it. They've got a role, but they're in it to make money.
And if the duty of care was to the insured, would that happen?
That's what we're trying to do, is say you need to primarily have a responsibility, just like I do. I can't go in there and say, I know this is what you need, but I'm trying to save money and I make more profit if I don't do this. I don't have that incentive there to do that. My duty is to the patient, and this would put them in the same categories, their duty being to the patient.
And then the follow-up would be, if the duty of care was for a PBM was thrust upon them by this law, what would that do to the function of the PBM activity to try to bring efficiency to the purchase of drugs and plans and by providers?
Well,
would it make it less efficient? Would it?
I think
would it do away
efficiency.
with it? Would it ruin it?
Efficiency has a role,
Okay.
but and it it could potentially cut into somebody's profit they're making. But we also know that the primary reason we're there is to take care of the patients, and when care is denied to these patients, healthcare suffers here. And I've seen people that were not able to get the medicine they needed.
How many do other states require duty of care to the insured?
I know there's a number of them that are looking at it right now, and I'll let some others speak to that, but I believe there's about 9 that are looking at this.
9 that are looking at it?
Yeah.
Real quick, Chairman Huffstadler, I want to thank Chairman Harbison. He sent me over a definition, and I think it may be as we talk about duty of care, I think it might be something to keep in our minds. The duty of care refers to the legal obligation of a person or organization to act reasonable or to act with reasonable care to avoid causing harm to others. It encompasses the responsibility to take appropriate steps to protect individuals from foreseeable risks, ensuring their safety and well-being. Key aspects being reasonable cares, acting in a way that a prudent person would under similar circumstances, foreseeable harm, anticipating potential risks, and taking measures to prevent them. And I think that's what we're trying to get to, right?
Correct.
Is when we talk about duty of care, that we're, to your earlier point, all the way down to the level of the patient, right?
Correct, and I'm sure that was written up by a lawyer, not a healthcare provider, but I think that's a good definition.
Well, I think probably a good Marine came up with it and shared it with Senator Harbison. But
I need to get his advice on a lot of things then.
yes, absolutely, he's a good guy. But so I think that just kind of clears it up so that we understand we're not asking for some Herculean lift. We're just asking people to do what's right, what's reasonable, and with the patient being our primary focus. Correct?
Correct.
Okay. Any other questions from committee at this point? Senator Huffsteller is going to be here throughout the committee meeting if we need to call him back up, but I want to keep the balls rolling. So you were saying that there's somebody here that could speak to what's being done in other states?
Right. I don't know. We've got a number of people, so they can determine who's the best one. Maybe Bethany Shearer would be the
Okay. Well, Miss Bethany. Okay. Well, Bethany has moved herself from under the bus and is sending somebody else up here. If you'll sit over here, ma'am. If you'll sit in the seat that Chairman Huffstetter was sitting in, and that mic is hot.
All right.
If you could tell us who you are and who you are with.
Yes. Well, good morning. Thank you so much for the opportunity to be here. My name is Sarah Baylog, and I am the Senior Director of State Policy for the Southeast for Pharma.
Okay. What is pharma?
The Pharmaceutical Research and Manufacturers Association. So we are the trade association that represents 30 member companies who manufacture brand medications.
Okay. Do you represent every manufacturer of brand medication?
No.
Okay. Can you give us a couple of your members' names of pharma companies that we may be familiar with?
Sure. Amgen, Johnson & Johnson, GSK, Novartis.
Okay.
Yep.
Thank you. And you're free to discuss the legislation and anything that you would like to clear up that you've heard so far.
Sure. No, I have really enjoyed the discussion, and the senator is exactly right. This is really just about leveling the playing field and extending the same duty of care, really to all the stakeholders in the healthcare ecosystem, to include PBMs, because as you've noted, providers, hospitals, health insurers, they all have that same duty of care, and so this would really just extend that to PBMs, who are a huge stakeholder in the healthcare ecosystem.
And give me that list again. The ones you just said have a duty of care.
Really, everyone in the healthcare ecosystem. I mean, doctors, providers, facilities, health insurers. Everyone has a duty to act in the best interests of the person that the person or entity that they're serving,
Including your members?
Yes.
Okay, because, and this is a very frank meeting. In years past, we have seen failure within that industry to show duty of care. Would that not be true?
I'm not an attorney, so I can't and don't represent our legal department, so can't speak to legal cases. I'm sorry.
And so you and I are standing on level ground, because I'm not an attorney either. But what I am is someone who reads the newspaper, watches the television, researches probably beyond my own mental health to determine what's going on. And I'm also a retired law enforcement officer who worked in the drug field for many years and saw the reckless lack of duty of care within your community, your members, and others that we're talking about here. And to the point that it's gotten so sideways that we've had CEOs of healthcare companies assassinated, and just yesterday or day before, healthcare executives from large healthcare companies being evacuated from their homes because people were driving by and shooting at them. And so your profession or your members and other individuals represented by people in this room, I think, have duty of care seems to have been a forgotten principle in there. So I just want to make sure going into this that everybody shares responsibility for the good that is happening in our healthcare, and absolutely for the bad that the good men and women who are getting up this morning in Atlanta, Georgia, going to work with health conditions and other things that need to be addressed. So as we talk about duty of care, I think everybody's going to have to share some responsibilities, but I would love to hear your members and your organization's position on Senator Huffstedler's legislation as to why y'all feel that way.
Oh, okay.
Thank you.
Thank you. Thank you again for the opportunity to testify in support of SB60, a bill to bring accountability to pharmacy benefit managers by articulating the duty or standard of care that PBMs owe to their clients, providers with whom they contract, and covered individuals. PBMs exercise an enormous amount of influence in the prescription drug market, from negotiating rebates with manufacturers, setting up pharmacy networks, administering pharmacy benefits on behalf of plan sponsors, crafting utilization management protocols, setting up formularies, and operating mail order, specialty, and retail pharmacies. PBMs are supposed to help lower costs for medicines, but they often enrich themselves over the interest of patients and their health plan clients. For example, the 3 largest PBMs also operate mail order, specialty, and retail pharmacies, and often require patients to use a pharmacy that the PBM owns or in which the PBM has a financial stake, even if there may be another pharmacy.
Real quick, and
Yeah.
explain to us how they do that. Help us understand how they would direct somebody to. I think I heard somebody say a while ago that there's a big
Steering, yes.
Yeah. Okay.
Yeah.
Tell us how they steer.
Well, so they essentially make it a requirement. When the PBM contracts with the insurer to provide those services, they then require that script be filled at one of their pharmacies, whether it's through mail order, whether it's a retail location. It's just they set up as part of their services and their contract with the insurer that scripts must be filled with their vertically integrated
Is it almost an in-network kind of model where if I decide to go with a particular health insurance, I can only use certain doctors within the network, or I can only use certain healthcare providers within the network, and if I decide to go outside the network, then I'm not covered and I have to pay the full cost or a higher percentage?
Yeah, that's an apt analogy.
Right.
It's hard to make that say that it's exactly like that, because the contract, PBMs in a lot of ways operate kind of in a black box. There's not as much transparency into the way that they operate. And so I think you're exactly right. From a layperson, man, woman on the street, that's a good way to think about it, that you're essentially being told you have to go to this pharmacy when you may want to go to one that's closer to you, or one that you've had a local pharmacy that and have had a relationship with the pharmacist, but you can't do that because it's not part of the vertically integrated system that the PBM owns.
So who does the PBM sign the contract with?
With the insurer.
With the insurer.
Yes.
So, and when they sign the contract, the insurer is aware of the PBM's relationship with these pharmacists or pharmacies.
Yeah, we assume so, but
Yeah.
again, can't speak to those contractual.
No. Yeah, I understand. I was just, for someone who's inside the arena as you are, just trying to figure out early on how the insured group would be able to find out if that happens. If going in the door, they know that there's an opportunity that PBM has a secure group of providers that they're going to say, this is the price I can get you, but you have to go to this pharmacy to get it. Right. Yeah. Okay. Thank you. Carrie, go ahead, ma'am.
Okay. Moreover, there are no requirements that PBMs share rebates and discounts that they negotiate from drug manufacturers with the clients they serve, health insurance companies, employers, state agencies, or patients.
Now, real quick, who provides them the rebates?
The manufacturers do.
Your members?
Yes.
Okay. And your members provide them the rebates, why?
it just, it's part of the marketplace, you know, of the process of selling our products.
So in the process, right. So,
Right.
so your clients manufacture the medication, and
Right.
there's a terribly expensive cost beyond many people's comprehension of how much it costs to actually develop and get a drug to the market.
Yes.
And so, what is the advantage after y'all invest all this money to give a discount or rebate to a PBM?
You know, again, I can't speak to individual companies. You know, that's proprietary pricing decisions.
Well,
I'm not authorized to
Right,
speak
right.
to.
And I'm not asking you to speak to an individual company. I'm just asking you to speak to a practice within your association's members. I'm trying to understand, because believe me, I know more about orphan drugs and everything else than anybody who's a cop would ever want to know. So, but wouldn't you say it's to get their drug out there on the market and
to get it, you know, covered by a plan, essentially,
right.
to get it on a formulary.
but to hopefully get it out there to the people that need it, the patients that need it, that it's supposed to make better, right?
Exactly.
Okay. So in order to do that, sometimes I guess concessions need to be made, or the competition's going to beat you to the punch, and their shareholders are going to make more money than yours, right?
I mean, I think that's probably
Yeah.
a
I'm
fair
not attacking. I'm just,
description. Sure.
Everybody's in it. Everybody's in it for a profit. I agree. Thank you, ma'am. You can carry on.
Okay. And again, as we discussed briefly earlier, you know, because PBMs operate almost entirely in a black box, health plans and patients often do not know about the conflicts of interest that can arise in the PBM's decision-making process. Expressly imposing a duty or standard of care on PBMs and requiring these companies to act in the best interests of their clients, providers, and patients, and when in conflict, in the patient first, would be a critical step for, you know, just ensuring that patients' needs are being met. That's why this legislation is important. By establishing a duty of care for PBMs, Georgia can ensure that PBMs act in a transparent manner and place their duties to patients, providers, and their clients before their own financial interests.
Very good. Now, how many do you represent an area for the?
Yes.
What area do you represent?
Tennessee, North Carolina, South Carolina, Georgia, and Alabama.
Any other states promoting legislation like this?
Not in my region, but I know that there are others in other parts of the country, and I can certainly get those where we've seen bills like this. I can certainly get that list of states for you.
I would greatly appreciate that if you could, and get it to our office. We would love to share it with the committee, the full committee, and let them look at it. Is this model language within this bill?
Yes.
Okay. And so all these, as intelligent as the carrier is, and I will tell y'all did get the right guy to promote your legislation. This was developed within.
This language was developed in conjunction with our legal team. Yes.
Okay, with your legal team, with your association.
Yes.
Okay, thank you very much. I appreciate that. Who I want to come up now, Cash, if you would go. Oh yeah, just
have one question.
Sure.
To your membership, your duty of care is to the end user. Is that right?
Yes.
Is it your duty of care to supply pharmaceuticals at the lowest possible price?
Well, duty of care is a legal term of art that.
No, I'm a moral term of it. Just what's your duty of care?
Certainly, I mean, to the patient to provide, you know,
What?
quality,
Provide
and
what?
a safe product to the patient.
A safe product to the patient at any price, or at the best price, or?
Well, duty of care doesn't, as I understand it, is not something that speaks to the cost of a service. It's just in the way that the service is rendered.
So it's your duty of care to provide pharmaceuticals that work that nobody can afford?
I don't believe that duty of care in that sense speaks to the price of a service.
Okay, thank you.
And exactly, and as we talk about this, do you feel there, and again, understand, and I don't mean this in a derogatory way, it's used derogatorily sometimes, and I don't think it should be, but big pharma, drug manufacturers. So duty of care is not a moral question. Duty of care is just a basically responsibility that we hit all the boxes when we leave from the research down to the patient, and that we protect everything there, and cost doesn't roll in the door on that. Is that right?
As I understand the legal definition of duty of care doesn't
Again,
speak to
Senator Hodges and I are not talking about the legal. We're talking about the moral obligation within all of these industries, whether we're talking about hospitals, pharmacies, PBMs, or whatever. Would it not be true that when we're talking about legal terms, a lot of times we're not talking about morality. We're talking about shareholders, we're talking about scientists, we're talking about individuals working in pharmacies and hospitals and in healthcare systems that are just there as a train, each box having its own responsibility to get the drug from point A to point Z, right?
It's a very complex process.
Thank you, I appreciate it. Yes, sir, go ahead. Yes, sir.
All right, I think what your clients do is they try to provide drugs at a cost that is efficient, that allows a good return to their shareholders, which they should have, their investors, enough money to provide for research, and then a drug that is affordable, something that people can use. That's probably what you do. Would you say so?
Certainly.
Now, is that what your duty of care is? Does that jive with your duty of care?
I think it's just important to, there's certainly, the moral and the legal are both, they're both there.
Okay.
I just can't.
I'm just trying to get my arms around duty of care, that's all. Okay.
And I think he was helping you, is exactly what he was doing, trying to help you understand that a lot of people see duty of care as being responsible, because I think it's obvious, and again, alluding to the horror stories over the past few years, that what seemed to be paramount was getting the drugs out, not to where they were going and not to carrying out the functions that the scientists who spent their lives creating them had intended them to be used for. So I think trying to find a pulse in duty of care seems to be a little difficult at this point. But thank you very much.
Can I ask one
Yes,
question?
Senator Harbison.
Yes, ma'am. One question regarding the rebates you mentioned.
Yes.
Is that a set figure, or do the people who operate the PBMs, can they negotiate that with the manufacturers? And is that the crux of the matter, that they're expanding what they're demanding from the manufacturers, or is that in the ballpark? Is that what's driving the cost? Are we going back where we were before we established the PBM, other than the duty of care that we're trying to control them with? I use the word control, but capture that, make it more reliable to the people who need the care.
Yeah, so the PBMs do negotiate with manufacturers, both our members and companies that are not our members, to get, to negotiate a price and a rebate for drugs, and the PBMs are not required to pass that rebate on either to their health insurance client, to the patient. That's a part of that contract and that negotiation with the manufacturer.
They're not required to pass the savings on, you said, is that right?
Correct.
Okay, thank you.
Okay.
You're popular, Senator Hodges.
those rebates that we're discussing, I mean, that's basically bulk purchasing, right? If I buy 10 of something, I'm gonna get a better price than one, if I buy one.
Yeah,
right?
rebates that's all just part of the contract negotiation between
Right.
manufacturers and PBMs.
And if
yeah.
your manufacturers wanted the PBMs to pass the savings on to other people, that could be part of their negotiation, could it not?
I believe that, state law is what, for state regulated plans and federal law for ERISA plans, the law, you'd have to essentially, I mean, certainly it's possible that PBMs could voluntarily choose to pass on rebates, but that's not a pattern that we've seen.
But the law proscribes that? Does the law in Georgia proscribe that?
No, it does not.
Okay,
Well,
so you could, so if you're negotiating with a plan in Georgia, or excuse me, if you're negotiating with the PBM and you're giving them a discount in Georgia, you could say, I'll give you a bigger discount if you'll take some of that money that you're making and pass it on to the end users.
I'm not authorized to speak to the contracting process.
And I appreciate that, but that's exactly the question that we were asking. These are negotiations. If I'm negotiating a price with Ford Motor Company to sell pickup trucks, doesn't it seem reasonable that if they offer me a discount, they'll say, Mr. Robertson, we'll give you this discount, but we want 50% of this discount to go to the sticker price so that the customer that comes in and buys our vehicle gets a cost savings. I mean, using something very simple. And so negotiations are negotiations. And are we trying to put guardrails on negotiations?
No, I just that rebate pass through is not something that we have seen happen voluntarily.
Then why do y'all offer the rebate?
Again, it's just part of the negotiation process for getting medications.
Would it not be true? It's part of the negotiation process to get your medications out into the consumer, so that the physicians can prescribe them and recommend them, because we do know physicians steer their patients toward particular types of medication, whether it be generic, whether it be name brand. And do y'all go through the same negotiations with independent groups, say independent groups that represent independent pharmacies? Do y'all do that the same way also?
The negotiation doesn't happen directly with the pharmacy. It happens.
I'm not talking about with the pharmacies. I'm talking about the groups that represent PSAOs.
Sure.
Okay, so do y'all offer the same kind of discounts and rebates and benefits to the PSAOs?
So again, I just can't speak to the contracting process because I don't have.
I'm not asking you to give me details about a particular contract. I'm asking you about a practice.
So it is not the intent of this legislation to capture PSAOs in this bill.
Why not?
That's just not part of the approach that we're trying to take.
That's not your target.
Right.
PBMs are your target.
Correct.
Thank you. I appreciate that. Gentlemen, Cash.
Thank you, Mr. Whip. Members of the subcommittee, Cash Betty with Capital City Public Affairs, and we represent the Pharmaceutical Care Management Association, which is the National Trade Association for the Pharmacy Benefit Managers. And with me, I have Michael Power, In-House Government Affairs with PCMA.
All right. Mr. Chairman, members of the committee, thank you for the opportunity to be here today to talk about Senate Bill 60. As Cass mentioned, my name is Michael Power. I'm with the Pharmaceutical Care Management Association, and I apologize, I'm not better looking than he is. That conversation was earlier, sorry. So came here today to talk about Senate Bill 60, but I do think it is important to address some of the comments that were made by some of the previous speakers. So as Cass mentioned...
And let's get to the comments made by the previous speakers after you speak to the senator's bill.
Okay, sure.
Thank you.
So Senate Bill 60, as it's written, I think the duty of care issue. PBMs do have a duty of care, and we have to act in good faith and good dealing to our plan sponsors. So PBMs contract directly with employer groups, the state health benefit plan, unions, trust, Medicare, Medicaid, to administer the prescription drug benefit. And so we do have language in our contracts where we have to act in good faith and good dealing with those entities. And so to go further to apply it to the patient, provider, and the health plan is just another layer. And the health plan does have a fiduciary responsibility back to their plan sponsor as well. So some of this already exists and is already happening today in the marketplace. Another issue that we have with the bill, the definition of spread pricing, it's defined in the bill, but it doesn't seem to be used in the bill. So it's just sort of a question as to why it is in there.
Okay, do me a favor, slow down a little bit.
Oh, sorry.
You threw spread pricing in there? Or-
Yeah, so that's
Yeah.
defined on page 6, lines 145 to 148.
And the layman definition of that is profit?
So if you are a plan sponsor, it's like a small employer, and you don't have a lot of working capital to provide a prescription drug benefit or healthcare coverage, and you would like to, spread pricing generally is part of a spread contract where they have price certainty throughout the year. So they are charged a fixed fee to provide that benefit to the lives that they cover.
And it is the PBM's responsibility to go out and negotiate prices below that?
So yes, we provide a list or a price of drugs that are in that plan from A to Z. And if a patient in that plan goes to a setting where the drug is more expensive, that plan sponsor is just charged the price that is in the contract.
I understand. You're talking the pretty side of it. There's a ceiling,
Yes,
and that client cannot be charged above that ceiling.
right.
What if you negotiate a price that is below that ceiling?
If it is, then that is the benefit to the PBM because they've taken on the risk if it goes above.
So if I give you $100 for a particular drug to go out, $100 is my ceiling, and the drug costs $125, then you lose $125 against your
25.
margins.
Yes, sir.
Against your margins. But if you go out and negotiate it for 80, then that 20 between 80 and 100 goes into the profit side, correct?
Yes, sir.
Okay, thank you.
Thank you. Thank you for the question.
Yeah.
So that sort of highlights the sort of the high level issues with Senate Bill 60. This bill, versions of this bill have been introduced around the country. I think Virginia was one of the states with the most activity. That bill did not make it out of committee. There were some questions there and some issues there that I think this committee has been addressing. So I'll stop and be happy to take any questions or just go into more detail about some of the questions that were asked earlier.
Any questions on his comments related to the legislation? Okay, Senator, anything yet?
I don't
All
know
right,
if
let's, your retort to the previous comments.
Sure. So as it relates to the rebate discussion, so PBMs do negotiate with drug manufacturers on the rebates. And so it is important to note there are about 70 full-service PBMs that operate in this country. And between those PBMs, they manage about 275 million Americans' lives. And so they use that buying power to go back to the drug manufacturers who do manufacture the product, who do invest in research and design, they do invest in marketing the product, right? So we go back to them, and once they've set their list price for the drug, we then negotiate off that list price the rebate dollars. And we do that by aggregating all the buying power of the people in this country that we represent. Then those rebates, depending on the plan design, so if a spread contract is in place, there is a different rebate structure there. But generally today in the marketplace, 98 to 99% of the rebates go back to the plan sponsor. And in the case of Georgia, the state health benefit plan gets 100% rebate pass-through. So those rebates are then being used by the plan sponsor to either smooth premium increases for the beneficiaries of that plan. They may use a point-of-sale rebate option, or they may use those rebate dollars to offer some sort of a healthy program for the beneficiaries of that plan to, get your steps in and get a free monitor or something like that.
So to be clear, the state health benefit plan of Georgia, the rebate goes to that plan?
Yes, sir.
Okay, so the PBM does not make, we don't run into the ceiling or the ceiling's still there, but the floor is not.
Yes, sir.
Right, okay.
Additionally, I think it was brought up about us operating in a black box. I think as everyone in the Senate is well aware, PBM's issues have been front and center for quite some time. The state of Georgia has a number of laws regulating PBMs, including a bill that passed in 2020 relating to reporting and transparency back to the Department of Insurance. Our members are complying with those reports. We provide 3 reports annually back to the Department of Insurance, as well as a aggregated rebate report back to the Department of Insurance and our plan sponsors. And then we also have to file an annual attestation. The department has modified the report that we do provide 3 times a year, and those reports are due tomorrow. And so we are complying with those transparency reports that are being given back to the Department of Insurance.
And I will point out to the subcommittee members that you do have an executive summary of the January 1, 2023 through December 31st, 2023 Pharmacy Benefits Managers Monitoring Executive Summary of PBM Annual Data Call Analysis. This is the summary. They're in the process of printing off the full report with redactions, and it was too voluminous for me to bring in here now because of the data points that our commissioner and his team have put together, which is phenomenal, the work they've done on it, and I appreciate that. Any questions for this witness? Your mic is hot.
Thank you. I have several. You're saying that your duty of care is to the people who hire you.
Yeah, to the plan sponsor.
Do you have any duty of care? Do you consider yourself having any, as a PBM, any duty of care to the insured,
To the patient?
to the patient?
Yeah, I mean, so it is, we have tools out there, utilization management and step therapy, prior authorization, and those tools are designed, their intent is to benefit the patient. Now, we understand there have been some issues with those tools, and we are looking at how we improve those tools to improve the patient experience.
Is that the extent of your duty of care to the patient?
At the end of the day, we work for the plan sponsor, right? And so in considering the full coverage of healthcare, they have, the iron triangle of healthcare. You have cost, access, and care. And so it is part of our role to balance that access to the plan sponsor primarily when they're responsible for about 80% of the cost of providing that care.
But your primary duty of care is to the people who hire you.
Correct.
Okay. Secondly, the rebates to plan sponsors, if a plan sponsor wants to share those rebates with their members, do you care?
We do not. If it's a plan design that's available for plan sponsors today.
Okay. Next question. Do you make money on fees only, or how do you make money?
So no, we don't make money on fees only. So when it comes,
do you get fees?
so we do have a fee structure from either the plan sponsor. So there's administrative fees, right?
Right.
So for processing a claim, if we are talking about the fees between the PBM and the drug manufacturer, there are fees that exist in that space as well. One of those fees is actually a data fee. The drug manufacturers like to know the utilization of their medications, and so there is a fee that PBMs charge for that. And there's a few other fees throughout the process as well.
But you also make money on spread pricing?
If a spread contract is utilized, but that is largely
The
that
net
is
of
a
over
smaller.
and under, the net of over and under is yours.
Yes.
Okay.
But most plans today have moved away from spread contracts and are using a fee for service. So they're
Just
literally
fee.
paying for every transaction that occurs.
Okay, so you can make money other than fees, but the industry's moving toward fee only?
Yeah, the plan sponsors have they're moving away from using spread pricing and contract. It's usually a smaller employer that may still use it today. I mean, by small employer, someone who employs less than 1,000 employees.
Two more questions. Do you consider PBMs to be honest brokers?
I do. I think
And
there
why?
is why. We are hired to do a job. And as a result of doing our job, if we're doing it right on behalf of the plan sponsor, we're going to create friction points between the independent pharmacy community as well as the drug manufacturers.
Including those that are vertically integrated?
Yep. So that's been, that was a comment that was raised earlier. Again, there are 70 full service PBMs that operate in the country. There's only one that manages a retail pharmacy or owns or has a retail pharmacy relationship.
There's one, I'm
Only
sorry,
one.
say that again.
With
One
a brick and
One
mortar.
of 70?
One of 70, yes. Then there are
One of
others.
70 is vertically integrated. Owns a retail pharmacy.
Owns a retail pharmacy, yes. There are others that own a specialty pharmacy and a mail service pharmacy and have a health plan component as well.
So how many are vertically integrated?
I think with the way that it's commonly defined is there's probably 5 companies that have a health plan and a PBM as well as some sort of pharmacy delivery mechanism.
So one owns a retail
Correct.
and another 4 have some type of vertical integration.
Yes, sir.
Okay. And then my last question, would PBMs be more, would the end product, the more efficiency of pricing of drugs be better off if PBMs could not be vertically integrated?
if we could not be vertically integrated, would the pricing be better?
Right.
Yeah, I think that's $1 million question, right? I mean, the
Was
PBM
it-
itself.
Question, is it $1 billion question?
Well, I mean, it's $1 billion question. I mean, the PBM itself is the entity negotiating against the drug manufacturers for the discounts in the form of rebates.
And if I didn't have to direct people to my pharmacy, if I'm a PBM and could just shop around and get the best price anywhere, would that be more efficient?
So we do have any willing provider laws in most states in the country, including Georgia, and we also have network adequacy requirements through CMS, and so we have to have pharmacy locations that are accessible to all patients covered by the plans.
Okay. And then one last question, this is just an aside and you don't even have to answer it, but do you think that mom and pop pharmacies have any future at all?
The market's changed. There's no easy answer to this. I was having this conversation yesterday in Columbia, South Carolina. We're seeing, I mean, retail pharmacies are closing as well. You have more players in the pharmacy space. Walmart offers delivery of drugs with their product, with their groceries. Amazon is getting into the business now, which is not a member of ours. And so there are a lot of other new players that are coming into this space. Kroger, the one near me, I don't know how this is legal, is offering an incentive to patients who move their prescriptions over, $25 in free gasoline if you move one, and $50 in free gasoline if you move 4 prescriptions. And so there's a lot of competition now in the space, and it is making it a challenge.
Thank you.
Cash, anything else y'all want to add to this?
I'm just here for my good looks, Mr. Whip.
Well, they're not here yet, but when they get here, we'll let you know.
Thank you.
Thank you. Anybody from the healthcare industry want to come forth and please share your identity with the committee, and let's talk about Chairman Huffstedler's legislation.
Yes, sir. Good morning, Mr. Chairman. My name is Michael Riley. I'm the Vice President of the Georgia Association of Health Plans. I'm standing in for our good friend, Mr. Jesse Wethington, this morning. So here to talk to you about Senate Bill 60 and sort of the health plans perspective. I don't want to reiterate what the PBM industry has said, but we do have some comments of our own. So diving in, on line 80, PBM services, that definition is very broad, and based off of that, we're not sure who is and isn't considered a PBM. An ERISA exemption should probably be included, and large employers should be concerned that it isn't in the bill. The PBM duty piece, which we've spoken about quite a bit, mentioned on lines 111 and again on 180, 185, 192, and 198 is a little convoluted. We're not sure how the same duty can be owed to 3 different entities with differing interests. And we think that Senate Bill 60 is an attempt to regulate private businesses, private business-to-business contracts, which we don't tend to see in other industries.
Real quick, let's talk about the different interests of the 3 that you're talking about.
Yes, sir. So when you look at, let's see, let me get to that portion of the bill. So lines 185, 192, and 198, which is section 3 of the bill, talk about different duties. I think the best way to explain this is how are you going to have a duty to the insured person to get them the best cost appropriate for a drug, and then again to the person who is trying to make the most money they can selling the drug. To use a real estate example, real estate agents don't try to get the highest price possible for the buyer and the lowest price for the seller simultaneously. So we're not entirely certain how this section is supposed to play out.
Okay.
Sorry. The definitions of, excuse me one second. Pharmacy benefits management services, which is on line 80. Very broad. It says it means the following: the negotiation of the price of prescription drugs, the management of any aspects or aspect of prescription drug benefit, the processing and payment of claims for prescription drugs, processing of prior authorization requests, adjudication of appeals, the performance of any administrative, managerial, clinical pricing, financial, reimbursement, data administration, or reporting or billing services. So kind of what does this not include? It sounds like anyone who deals with the drug is a PBM in some way, shape, or form. We don't understand what isn't considered a PBM, and it sort of seems to suggest that everyone is a PBM based off of this definition. And I think so for the ERISA piece in Section 2, so you're looking at, I believe, what is language in the Rutledge Supreme Court case, and I'm not a lawyer, so I don't know too much about that case in specificity, but I do know ERISA, and I'm sure most of you guys are familiar with ERISA and ERISA plans. It's the Employee Retirement Income Security Act of 1974. It establishes standards for private sector employee benefit plans in the United States. Self-funded, self-insured plans, which many large employers use. It allows them to opt for paying employee claims directly instead of buying insurance. And so we think that ERISA exemptions, like we've seen in many other pieces of legislation, should also be included in this if it were to move forward. And then finally, I would say that based off of the definition of PBM services, lines 208 and 209 at the very end of the bill, a person who is aggrieved by a violation of this code section may bring a civil action before a state court. So if, based off of the definition of PBM services, practically most people in the healthcare chain could probably be considered performing some sort of PBM service. So this is a cause of action for folks who may not necessarily need to be looped into this.
What would be your language to correct that?
I don't have language for you now, sir, but I'd be more than happy to get that for you.
Have you had the opportunity to meet with the author of the bill?
We have tried to meet with the author of the bill. We haven't been able to connect.
Well, he's a very busy guy.
Yes, sir.
Yeah, and but with something this important, yeah, I'd be a little surprised, as open as he is. Senator Hodges.
What would you think the duty of care should be for a PBM?
I think the PBM has a duty to the sponsor to save money, if possible. While I'll echo Michael's comments, PCMA, we believe that the industry exists to negotiate prices, and those prices for employers who use PBMs help keep their healthcare costs low, and we appreciate that service that they do.
Do they have any duty of care to the insured? To the patient?
I believe so.
What is that?
That's a great question, sir. I'll have to get back to you on that.
And I'm going to ask him to make sure you do.
Yes, sir.
Hypothetical.
Yes,
What
sir.
does a world without PBMs look like?
Another great question, sir. I think I'd heard in comments this morning that they've been around for 20 years. It's a new model. It's a new mechanism. Healthcare innovation is changing rapidly. We have different ways in which we try to help reduce the cost of insurance and healthcare, and I think PBMs do probably play a key role in assisting us in that. But as to what they look like without being here, I'm not sure.
Do y'all work with PSAOs also?
I do believe so. But I do not have any information on that.
Do you understand what a PSAO is?
I do not, no, sir. I'm batting cleanup today. And
Let's be clear. While Jesse is on his 1-year anniversary trip with his wife, right? Yeah. I'm sure he's listening though. Anything, sir?
I hope not.
It's only been a year. He doesn't understand yet. Thank you. I appreciate it.
thank you, sir.
I want to ask if he's comfortable with it. Skin, do you feel comfortable to come up and sit down for a minute and take a question or two? If not, I understand. I mean, you forgot to put your socks on, so it could be that kind of day.
Mr. Chairman, I think Cash and Michael were authorized to speak this morning.
All right. Very good.
I'd be happy to talk offline if possible.
Yeah.
I've got some strong feelings on some of the things that said, I'll say.
Yes, sir.
Say that.
All right. Yeah. Anyone else want to speak on a position with this legislation? Yes. If you'll come on up real quick, then please tell us who you are and who you represent.
Thank you for your time this morning. I'll be brief. My name is Collier Williams. I am with the National MS Society, a volunteer with our government relations group. I'm here today to express our strong support for the bill. Millions of Georgians rely on prescription medication to live fuller and healthier lives. Over 15,000 Georgians live with multiple sclerosis, which is a chronic and unpredictable, often debilitating disease of the central nervous system. For those 15,000 constituents that live with MS, access to this medication is not simply a convenience, but it's very literally a lifeline for them. Pharmacy benefit managers play a critical role in determining whether these drugs reach patients at an affordable cost or remain out of reach due to complicated pricing and profit-driven decisions. All too often, we hear stories about people skipping doses or rationing their medication due to high cost. In fact, the National MS Society conducted a survey where 40% of respondents said that they had altered or stopped taking medication due to the cost. This bill addresses this issue head on. It requires PBMs to put the patients first. It's a big step forward in ensuring that there is transparency and accountability for the PBMs, who maintain significant influence over prescription drug prices. So again, thank you very much for the opportunity to speak to the bill today on behalf of the National MS Society and Georgians everywhere that rely on prescription medicine. We respectfully ask that you advance the bill to full committee for consideration.
Okay. Explain to me again your role with the society.
I'm a volunteer with the Government Relations Advisory Committee.
Okay. And so the pricing, who do you think would be best to determine the pricing of the drug that your patients need?
I can't answer that question, Mr. Chairman, but I will say that what we're asking for today is transparency and accountability for those who are charged with that duty today.
Okay, and so when we get to accountability, who do you think the individual that's responsible for negotiating prices for pharmacies, do you think that they carry the same level of accountability as the company that manufactures the medication?
No, I do not.
Okay, so do they carry more?
I wouldn't feel comfortable answering that question, but I would love to follow up with you with some literature on that.
Yeah, and I mean, and the responsibility of a subcommittee is to ask the unpopular question. I hope you understand that. And because of my lack of popularity in this building, I seem to get tasked with this a lot. But it's a free market, right?
Yes, sir.
So would you agree that at some point patient care and cost of manufacturing kind of bump up against each other?
I would.
And would you also agree that most of us don't appreciate until we take a deep dive in it the actual cost of creating medication?
Yes, sir, Mr. Chairman. It's very
So-
expensive.
It is, and I've got several friends that suffer from this, and I greatly appreciate what you and the society do. What are we doing, and what is the society doing to work with pharmaceutical manufacturers to try to get the cost of these critically needed medications down?
Well, the society is doing a lot of work, but today we're
Please tell us what
focused
that.
on-
No. Today,
Yeah,
today I'm focused on finding out how we can get medication from the manufacturer, from the brain of the scientist, to the patient at the best, most efficient cost. That's my responsibility.
Yes, sir.
I don't carry a patch of any company, association, or anything else on my jersey. My responsibility is to find out what's best for the patient. If the PBM negotiating is best for the patient, then that's great. If the drug manufacturer not giving rebates, then I'm fine with that. Or if they give them, let's be honest and say why we give them. Because what I want to do is I want transparency so I can know why MS patients are having to skip doses so they can hopefully manage their pain a little longer. That's my concern. So are y'all working towards something to where we can get a solution like that?
Absolutely.
Okay.
And I would love to follow up with you with some information on that and what we're doing.
I'd love to do that, and thank you. And now we'll bring the author of the bill back up.
All right.
Thank you.
Thank you very much.
Hang on, just a second, ma'am. After we get through with the senator, I'll get you to come up.
So one thing I did want to say is everybody is in it for the money. Big Farm, I've been frustrated with the federal government not negotiating with them. The health insurer, the PBM, the health provider, such as me. People do it. They expect to make money doing it. We have other motivations as well, but no doubt everybody's in it for the money. There was a comment about ERISA plans. That's a red herring. I learned in surprise billing that I did some years ago that the Supreme Court decision in 2017 said I can't regulate, we can't as a state regulate ERISA. So you want to know why it's not in there? Because we can't put it in there. And I think the person that made that comment knows that. And he's right, there is differences in responsibilities to all three of them. There's competing interests, but it does say that while they do have a responsibility to all three, line 206, the pharmacy benefits manager duty owed to a provider shall be primary. And that's one of the points in there that we have, and there is a difference in that. This legislation is, it doesn't solve the thing. We kind of got off on rebates and stuff like that, which really isn't the intent of this bill. Though I will say that my understanding is 58 cents of every dollar that we spend on pharmaceuticals goes back by rebates and discounts, but that's not what this legislation is about.
And I understand that, but what this legislation is about PBMs. Mm-hmm. And what we have to do is we have to figure out what a PBM is. And we have to figure out what their role is within the system in order to I think, to make the right decision. And I think being fully transparent, I don't know that I would ever, I do know, I would never question the intent of any legislation you brought before anything I had to do with. And I think the intent of this legislation, knowing you, is that we get the absolute best price and best care for that man or woman laying in a hospital bed, or that individual administering whatever medication they have to do at home. And if PBMs are an obstacle to that, I think then it definitely needs to be addressed. My biggest concern sometimes is that individuals that come into these halls, and we know, I don't think we could do our job without the subject matter experts that stand in the hallways every day and provide us good information about the good legislation that we carry. What concerns me is, and we've all heard this and said it in a room with each other when it was just us, there's no interest like self-interest. And so I get a little tired when I see these champions wearing Superman capes up and down the hallway when their only concern is money, while they tout their concern for patients and hospital systems and everything else. And so that's my biggest concern. And
And one other thing, if I could add real quick.
you can add whatever you want to add.
For me personally, if a farm rep said, I want to take you and your wife to dinner, and I went to dinner, I would be fired for that. We work hard to not have steering. If I own part of a business and I'm sending patients over there, that's illegal. We all need to have obligations. I've got obligations. I appreciate them because it keeps people from pressuring me to do things that I know are illegal to do. This is not solving the healthcare system. This is just one thing saying, have a duty to the patient.
I agree. Now, Mr. Chairman, do you feel whatever regulation that we put on a PBM should also be put on a PSAO?
Well, go through the PSAO.
PSAO is a PBM for independent pharmacies.
I would agree to that, yeah. And I know we talked about there being 70, but there's really three.
Right.
Three PBMs run the whole.
Yeah, so you and I both know the percentage of facts, figures, and opinions that come out of that microphone when people involved in associations and other things are testifying according to things that are in their interest. But would you agree that, in full disclosure, my pharmacy is the Publix on Schaumburg Road in Columbus, Georgia, so I can buy groceries and get whatever medication my daughter needs at the same time. But would you agree that what we're talking about when we talk about name brand pharmacies and independent pharmacies, that the free market has to be a part of that conversation? And I've used this before. If a national steakhouse has a business in Columbus, Georgia, and I come across the street and build Randy's Steakhouse, I don't get to go complain that they get their meat at a better price than I do, right?
Right.
And I don't get to complain that theirs is a better quality than mine. And so sometimes the free market drives a lot of this, and I appreciate the fact that you started out this second portion of your testimony with the fact that it's all about the money. Mm-hmm. And I think what we have to do is drill down into this legislation and come up with the absolute most balanced piece of legislation we can, because this year we're swatting this fly. Next year we're going to be swatting another fly that was begat by this fly. And so I'm just, I get as frustrated as you do. Yeah. But anything else you'd like to say?
I did learn since then that Alaska has passed this, and yeah, there's legislation in Virginia, Nebraska, Connecticut. There's some other legislation in other states. They don't call it duty of care; they call it fiduciary care. Sort of the same thing, but you'd asked the question earlier, and I tried to get that information.
And I do know there's a movement over in Alabama. I had a friend reach out to me yesterday and said they saw somebody walking around the Capitol with a PBM button on with a red slash through it. So I asked them, could they see his name tag, and was it Huffstedler? And they said no. But so I do know that there's a lot of heat on PBMs and this vertical integrated system that's going on right now. But I really appreciate this, and I do want to point this out before I end this meeting. I want to thank the Office of the Commissioner of Insurance and Safety Fire for all the work they did, not only in helping us walking into this, but the work that they do and the thankless job that they do walking through this quagmire of health care that they have to manage for the state of Georgia every single day. And that we have an advocate over there who understands what's happening and stays connected to the legislation that moves through this building. Senator Harbison, do you have anything in closing?
I think you did a great job, Mr. Chairman.
Well, I don't know about all that, but I do appreciate you a lot for being my mentor and my friend. I want to thank Senator Hodges. I especially want to thank Chairman Senator Huffstedler for all of his hard work and for doing it always for the right reason. If there was a lady that raised her hand in the back, ma'am, did you want to come up and say something? No, we can follow up after. Okay, you wait until I turn my back, or are you going to throw something at me? Just want to be sure. Are you left-handed or right-handed? Both. I knew that was the way I'd die, an ambidextrous person. If nobody else has anything else, this meeting is adjourned.